This is 31-year-old gentleman with TB spine and portal lymphadenopathy on CT with biliary obstruction in October last year. He has ERCP done which shows 3 cm mid-CBD structure, and we put on a plastic stenting. US with FNB to the 3.9 cm lymph node at the portal region proven to be Mycobacterium tuberculosis infection. And therefore, he's been treated with the TB treatment for 18 months all total. And follow-up ERCP still shows a 3 cm persistent mid-CBD structure. And with the CT abdomen done shows slow decrease in the portal lymph node size from 5.6 to 3.9 cm only. So we wish to rule out persistent TB infection in the lymph node and also define the duration of the treatment with microbiological tests. This is his imaging on the CT abdomen, shows the large persistent lymph node, and with his ERCP imaging showing the mid-CBD structure. Today we'll perform 2 procedures. First of all, we'll proceed to EUS with FNB to the persistent lymph node for both histology and microbiological culture first, and followed by ERCP plus fully covered SEMS to the mid-CBD structure.
We are in the duodenal bulb, and as you can appreciate, we have a large lymph node, about 25 millimeters in size, that we are going to sample. Obviously, it's enlarged. Obviously, it's enlarged. Now, you know, by looking at it, it's very difficult to tell benign or malignant. So, as was presented in the case, we're going to use a needle to take a fine needle biopsy, not an aspirate, but a biopsy, so that you can do all the special staining and molecular staining that it's necessary to evaluate this patient. So we're going to use, yes?
Would elastography or contrast enhanced US be helpful for differentiating?
Absolutely. And we can show elastography for a second. And what it's going to show is whether it's a hard node, and that was a very nice image. Whether it's a hard node and it would look all blue, or whether it has all these different colors. The closer to green and red is soft, and the closer to blue, it's hard. So, as you know, elastography represents the elasticity of the tissue against the probe. Can we go to back normal function?
Does it help you to target the area? Would you prefer
Well, investment.
to puncture one of the softer parts or the harder parts?
Well, some people make the argument that it helps you select the best area for the lymph node. I am not such a big believer, but you could make the point. So if I could get the box of the needle, turn it around. So what we're going to be using is a needle called the Acquired needle by Boston Scientific. And I'm sorry about my drawing, I'm not very artistic. But the tip of the needle, the difference of this needle is that the tip has like a mouth. Imagine it has 2 spikes. So this is cutting spikes. And the thinking is that that design of the tip of the needle will help you acquire more tissue. So that's the difference between conventional needles in the market. So it was a completely new design for EUS. And what we're going to be doing now is FNB. So there's a lot of ways to do this. I particularly don't use suction in my unit for FNA or FNB if I don't have to. But we're going to demonstrate a couple of techniques. So the first thing we're going to do is just do a standard sample with just the capillary technique, which means just making negative suction on the needle. And you can see the needle tip. And what we're going to be doing is, as described, very well by my colleague Shayan Barandarajulu is the fanning technique, which means we're going to, with the elevator, try to direct the needle to different parts of the lymph node. And you can see that I am just, with my hands, slowly pulling the stylet to do negative, almost like a vacuum within the needle. And especially for lymph nodes, it's important because if you do a lot of suction, you could potentially cause more bleeding within the node. So the mystery remains how many passes you do back and forth. I don't think anybody has that answer. We are very content with just moving it back and forth a couple of times and hoping that that cutting edge of the design will allow us to get additional tissue. So now that we've done this, we're going to take the needle and see what kind of specimen we got. One way to know if you got enough specimen is looking at the color of the tissue that comes out. In general, when you see white, that's a very good sign. When you see red, it's very difficult to predict whether you got any tissue whatsoever or not. So now we're going to empty the, flush the needle, put back the stylet first, and then flush it with air into this formalin container so that then it can be evaluated. So that is the standard technique for FNA, and that is the technique we use for FNB at University of Chicago. And the second pass, what I'm going to demonstrate is what we call a negative suction FNB. And Alberto Largi and us in our group described this some years ago, whether by using the dilating gun and causing negative suction, you're hoping to obtain a larger piece of tissue. And in our hands was very, very successful. So obviously, you know, by the morphology, I think it's impossible to tell malignancy or benign. It just looks like a very abnormal enlarged node. And as my team prepares the needle, we will demonstrate a second pass, and maybe do we need to open a new needle, or?
Can we see the aspirate? See, is there
I don't know if you have any questions so far.
can
Irving,
we see
how
the
important is
aspirate?
on-site evaluation on histopathology or cytology?
I think that in general, I think it's very important, but for nodes, the accuracy of FNA is so high that in my unit, unless it's dramatic, we don't usually call the cytopathologist for a lymph node. But for obviously for solid masses, etc., we think it's extremely useful and important if you have it. Is there anything to show? So let me put the needle in, and then we're going to show the specimen. So we don't have a flying needle in the room.
So you have no on-site
So
cytologist.
I don't know if you can focus on there. So at the bottom of the container, there's a piece of reddish tissue. And it doesn't look like clot to me. It's a little bit gray. So that's a very, very good sign. So on the second pass, we're going to illustrate a different technique that I like to use when it's really important to get a core, which is going to be utilizing a dilating gun and applying negative suction. So now in this case, we are going to remove the stylet, and we are going to attach, in this particular case, is the Boston Scientific gun that is used for balloon dilation. And I don't know if you can focus on the nurse's hands. So you can see the gun. Not on me, but if you can focus on the gun that we use for dilation. So now that I am within the lesion, I'm going to ask my assistant to do negative suction and go all the way to the red line. There's no reason to go there to the red line other than being superstitious about things. So let's do negative suction. just go. Yep. Keep going. So now that I have negative suction, I have a 3-way stopcock. I'm going to open it. And then the same technique, I'm going to be going back and forth on my node. And again, using fanning technique to try to get different parts of the lymph node. And the way I'm doing fanning is using the elevator and turning my body right and left. You can see the extent of the needle within the node. So now that I'm supposedly happy with my sample, when you see the needle, the resistance is because I'm hitting the biliary stent. That's why it seems to jump a little bit. So now let's see what we got with this technique.
Irving, this is a very nice demonstration, and I'm not an EOS guy, but according what I know, the meta-analyses don't show any significant difference in terms of the accuracy.
In comparing,
this suction or no suction, for example. Huh?
it doesn't show any difference. In my experience, when you do a lot of suction for FNA, for solid masses, you cause more bleeding. So we actually, our standard technique is 25 gauge, no suction, capillary technique. And our accuracy is close to 90%. And a couple of passes. And one of the things we're submitting to DDW is that with the Covidian needle, the shark core, with one pass, we can get pancreatic tissue in malignancy in close to 90%.
Okay, Irving, it was a very good presentation. We have to go to the
I
other
don't know if
room.
you can point on this to see the sample. Why don't you close it?
Okay, we saw the sample. I think we can switch to the other room.
Open? Okay.
Horst, we are with us? We're with you?
Yeah, so this patient obviously needs a long-term biliary drainage because of this compressing lymph node. And therefore, we will exchange this plastic stent against the fully covered metal stent. I think this is a good indication. And as you can see, I grabbed the plastic stent at the very distal end with a snare so that we can put it and pull it through the instrumentation channel. I will recannulate now with a clever cut, sphincterotome, and I cannulate at the upper edge of the sphincterotomy. So then I get at the very proximal edge here. I lift the papillary roof. Okay, try it again. Yes, biliary duct.
All right.
So we inject, please, some contrast. Yeah, as we can see, the narrow part is just above, inject a little bit more contrast, above the endoscope, below the EG junction, below the confluence. Yeah, there is the narrow part, so I push the endoscope inside. But it's not very impressive here. No. No, it's not as tight as before. But it's difficult to know if this is enough just to leave him without a stent. Huh? But there's...
There's a concern that he needs longer treatment, so that's why we want to have some secure period.
Yeah, I agree. So and the narrow part was probably at the mid part of the CBD.
Crossing the scope.
Yeah. So that means then we would need a 6 centimeter long stent. And before that, push 6 centimeter, 10 millimeter in diameter. And so push the wire forward a little bit. I will, okay, that's fine, it's in the left. And we will increase a little bit the size of the sphincterotomy, because when the stent fully opens, a fully covered stent, it may compress the pancreatic orifice, and therefore I prefer to have a larger biliary opening. And as you can see again, we have the insulated part of the cutting wire at the proximal end. We bend the sphincterotome and use the endocut mode, and I manipulate the shaft of the endoscope. So we are in a good direction. I don't touch the catheter, but just I direct the cutting wire with the endoscope and split the papillary orifice, the biliary orifice. And so at the proximal part, I leave only small part of the cutting wire inside. As you can see, only a few millimeters. I rotate the endoscope to the left to have some pressure on the papillary roof. Okay, that's fine.
Horst, I have a question.
So wire forward, and we don't need fluoroscopy because we have the markers. And what is nice here with the VisiGlide is that these markers show that the wire is at least 9 centimeters inside the duct. And here, just we remove the sphincterotome, and then I will show you how we can exactly measure the distances. So this is here the border between the oblique markers and the cross markers. And that means the tip of the wire is now exactly 9 centimeter inside the duct. And now it's 7 centimeters. So this is 7 centimeters inside where the oblique markers begin, and this is here at 9 centimeters.
Horst,
and we can check.
The question,
yes.
the question,
and therefore 6 centimeter should be appropriate. So this is a very helpful wire. So we have to finish the procedure because of the undersaturation of the patient. So we do it quite quickly. This is allows short wire technology, as you know. As you can see, I hold the wire here. Advance the stent quickly forward.
The question came up.
Okay.
The contrast medium is almost
Pull
out.
I pull a little bit on the wire. So, and I insert it until I see the marker. So here's the yellow marker. We start with release. We will finish, start with release. Start with release. We have to do it quickly. Go ahead. Go ahead. Release, release, release. So, okay, we see the release. Stop. Now I only watch the endoscopic part. Continue, continue, continue. Stop, 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 not too slowly. Continue. So we slowly, slowly, slowly. Okay. Okay, I pull a little bit. Okay. So it's nearly released. Okay. 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 So we have to finish the procedure. Yeah, we have an excellent position. Stent is fully opened because the patient is not in a well condition, but I showed you how quickly this can be done. We don't have to we don't need fluoroscopy a lot. we mainly focus on the yellow marker, which has to be outside of the papilla, so it's more done under endoscopic control.
Okay, thank you very much, and we will.
So can you please? Okay.